Well, welcome to this SIPFA webinar on prioritizing prevention, lessons from across the UK. Please note that this webinar is being recorded and will be shared on SIPFA's YouTube channel at a later date. I'm Zach Scott, a policy researcher on prevention at SIPFA, and I'm delighted to be moderating today's discussion. For those of you less familiar with SIPFA, we are the only professional accountancy body in the world dedicated exclusively to public finance. We represent 14,000 members globally, working across three core pillars: thinks, develops, and supports, to drive financial sustainability and good public financial management. As part of that work, we're focusing on ensuring the sustainability of public services and recognize the need for shifting toward a preventative approach. The case for preventative investment has never been clearer. Across the UK, we're seeing growing inequalities, increasing demand on acute services, and unprecedented pressures on public finances. While we all intuitively understand that prevention is better than cure, turning that principle into real financial priorities has proven difficult. In recent years, we've seen numerous reports and policy recommendations calling for a renewed focus on prevention. These include proposals for a community-powered approach that shifts decision-making closer to local communities, the creation of a new public expenditure category for preventative spending, a greater proportion of integrated care system budgets to be allocated toward prevention, and SIPFA's own recommendation, a twin-track approach that balances immediate service needs with long-term preventative investments, just to name a few. While there is broad consensus on the need for prevention, one fundamental question remains unanswered. How much are we actually spending on it? That may seem like a simple question, but in reality, it's anything but. One of the biggest barriers to investing in prevention is that it's difficult to quantify. Unlike acute services where spending is recorded in budget lines and financial reports, preventative activities are often spread across multiple departments and delivered in partnership with different organizations. This creates three major challenges. The first is a lack of transparency. Traditional accounting systems don't always distinguish between acute and preventative spending, making it difficult to track investment levels. There's also a variability in definitions. What one local authority defines as prevention might differ from another, leading to inconsistencies in measurement. And of course, the challenge in making a strong business case. In many cases, prevention delivers benefits over the long term, often across multiple services, and it doesn't always fit neatly within existing reporting structures. Without clear data on what is currently being spent, it's difficult to plan for the future and make the case for rebalancing budgets toward prevention. To help address this gap, SIPFA, supported by the Health Foundation, launched a project to explore the feasibility of quantifying local authority preventative spending. By looking at local authority finances through this lens, we aim to develop a clear definition of prevention that applies across different service areas and a framework to map and measure preventative spending within local government. Now, this research is limited to 4 councils in England, where local authorities play a key role in funding and delivering essential services. Since no one has ever attempted this before, we decided to start with just 4 councils, partly to keep things manageable and partly to avoid giving accountants across the UK a collective headache. Even within this small sample, we've seen huge variations in how local authorities organize their finances, allocate budgets, and define preventative activities. If we had tried to roll this out across the whole UK at this early stage, we would have been dealing with an accounting nightmare, one that not even SIPFA's best minds could untangle overnight. That being said, our ambition is clear. This is just the beginning. While this phase of the project is focused on a handful of councils in England, the findings will have wider relevance. We recognize that prevention is a UK-wide issue. and that the challenges of defining, tracking, and justifying preventative investment are shared. Today's discussion is an opportunity to bring together experts to develop insights that are worth being shared, adapted, and expanded across the UK. Over the next few hours, we'll be exploring what prevention looks like in practice and how it can be informed by the building blocks of health. The barriers to adopting a preventative approach, from funding challenges to policy constraints, and how we can make the case for investing in prevention in a way that's financially viable and politically persuasive. We're fortunate to have an excellent lineup of speakers who bring a wealth of expertise. Joe Bibby, Director of Health at the Health Foundation, and Paul Johnston, Chief Executive of Public Health Scotland, will open our first session, setting the scene for why preventative investment is so important. In our second session, we'll hear from Jim McManus, National Director of Health and Wellbeing at Public Health Wales, and Mike Burns, Programme Director for Child Poverty and Prevention at Glasgow City Council, who will discuss the barriers to prevention and the changes that we can make to overcome them. Finally, we'll wrap up with a discussion on investing in prevention, where Vicky Davis from the National Audit Office will share insights on her recent report on homelessness. And I'll pass the moderator role over to my colleague Elliot Roy and present CIPFA's work on exploring preventative investment and local government in more detail. We'll also have some short breaks throughout the afternoon, so please do grab a cup of tea or coffee and get comfortable. This is an important and timely discussion. While financial pressures can make preventative investment seem like a luxury, the reality is that prevention is a financial necessity, one that can help us create more resilient communities and ensure the sustainability of public services. The challenge is not just making the case for prevention, but finding practicable, scalable ways to implement it within the financial landscape. That's why today is about more than just sharing research. It's about having frank and open conversations on what's possible, what's working, and what might need to change. I encourage you all to join the discussion, whether through the Q&A or follow-up conversations. The more we collaborate, the closer we get to real, impactful solutions. I would also encourage you to learn more about the work we're doing by visiting our webpage on prevention and subscribing to CIPFA's LinkedIn newsletter. So with that, let's dive in. The first session of the afternoon looks at prevention and the building blocks of health. Although we often look to the NHS when it comes to prevention, in reality, there are so many factors that shape our health. Today, I'm delighted to be joined by Joe Bibby, the Director of Health at the Health Foundation, and Paul Johnston, Chief Executive of Public Health Scotland, to set the stage for the rest of the conversation by introducing the concept of the building blocks of health and what this looks like in policy and practice. So with that, I'll pass the floor to you, Joe.
Great, thank you very much, Zach. So I'm just going to share my screen. So I hope that is now visible to everyone. So, as I was introduced, I'm Joe Bibby. I'm the Director of Health at the Health Foundation, and we're really pleased to be working with CIPFA on this piece of work around prevention spending in local government. Our mission is to improve health and care across the UK, and the work I'm responsible for is related to the work we do on improving health and reducing inequalities. And by that, I mean we're focusing very much on what we call the building blocks of health, the conditions that we need to help people stay healthier for longer. I'm going to, in this presentation, just sort of go through some of the material we have that sort of emphasises the evidence behind the importance of having the right building blocks in place for people, for them to lead healthier lives, but also the role that local government can play in this, and why this focus on prevention is so important. But I'm going to start first of all with a video that is from a national campaign that we're running with 27 partner organisations. Its campaign is under the overall banner of Health Equals. And the campaign we ran last year was on Make Health Equal, and it was highlighting the difference in life expectancy that people have depending on where they live in the UK. It's a coalition, as I said, of 27 partner organisations, and they include people working across the sort of range of building blocks of health, and including the local government association. So I will now just start the video. It's just over a minute long. Okay, so I think clearly a very sort of emotive way of explaining some of the differences in life expectancy in the UK. But, you know, maybe just to accompany that with some of the analysis that we do at the Health Foundation. So this is a chart that we published last year that was looking at what's happened to life expectancy in the UK over the last sort of quarter of a century. And what might have happened. So you can see here the solid red line is the life expectancy that we have seen. This is data for England and Wales. And you can see how from 2000 through to around 2010, we were still seeing a steady increase in life expectancy. However, from 2010 onwards, that increase slowed down quite significantly, and you know, we talk about it starting to plateau. You can see obviously, you know, this the impact of the pandemic as well showing through. But this trend is concerning, that we're seeing this stalling in life expectancy, and we've kind of got a dotted line there, which is of course purely hypothetical, saying, well, what would have happened if it continued at the rates before 2012? And you know, that's showing a sort of steady increase of life expectancy. And, you know, of course, is this realistic? You know, maybe not wholly, but I think just to share this other chart that's on our website that looks at life expectancy in the UK relative to other comparable OECD countries. And you can see on this chart, I mean, I know the text is small in terms of the countries, but it lists the OECD countries, and the three sort of dots for each country represent life expectancy at birth in 2000, 2010, and then 2020 is the sort of darker red dot. And you can see that in the vast majority of cases, most countries are seeing life expectancy steadily increasing. There's a couple of exceptions to that, but there's sort of circled quite, you know, well, more than halfway down that table is the UK. And you can see there that our life expectancy is, you know, some around just under 4 years less than the countries that we see at the top: Norway, Iceland, Japan, and Australia. So I think what this tells us is that, you know, we should be aspiring to have higher life expectancy in the UK, and we should be asking ourselves, why do we not have that, and what can we do about it? So moving on to that, you know, the Health Foundation, we have one of the things we do is we try and explain the role of building blocks of health and prevention in improving life expectancy, drawing on robust evidence, but trying to convey this in a sort of more accessible way. And we have a series of infographics, which I'm just going to show a selection of some of them to you, that talk about how these building blocks of health, whether it's transport, housing, education, and so on, all contribute to giving people the opportunities they need to be healthy. So starting with housing, which clearly local government has a role in the housing stock of our country. We talk about the good housing needs to be affordable, it needs to be of a decent quality, and there needs to be security for people, that they know they have some security of tenure and so on. And just to illustrate why these things are so important, here's some stats from various sources that look at, for instance, what we know about housing affordability. So housing costs are unaffordable for more than a quarter of families on the lowest incomes. So clearly that creates a lot of challenges for families in terms of then subsequent affordability of other things that are important for healthy lives. 3.7 million homes are non-decent. 20% of private renters have lived in their home for less than a year, compared to 6% of social renters. So that sense of the sort of higher precarity in tenure for the rented sector. So these are all things that we need to be paying attention to and trying to address. Money and resources, clearly very important. Socioeconomic status being the thing that's most strongly associated with good or bad health. And money is important, it gives us that peace of mind, having savings to fall back on, and kind of meeting needs of both ourselves and children. And we know that people with problem debt are more likely to be experiencing anxiety. Half of working age people with poor health have no savings to fall back on, and a quarter of the UK's children are living in poverty. So these are all very concerning factors, and things that where local government, in some of the roles it plays, for instance, providing debt advice, support, and so on, are all things that it can contribute to. There's some great work that goes on, I know, in some councils, where they look at how they help people increase the uptake of what they're entitled to in terms of universal credit and other benefits. So all things that need some investment in order to help people to increase the money in their pockets. The food we eat, clearly vital. We need affordable food. We need to have control over advertising that doesn't just push poor quality food onto people, children, and so on. It needs to be accessible, and the right sort of diets. But some of the examples that sort of support the relationship around food and health, we know that a healthy diet is expensive, and this references the Broken Plate report from 2023, but this has also just been updated, and we know that the poorest people end up spending more of their disposable income on food compared to the wealthiest, if they're trying to have a healthy diet. Advertising, something that some councils are trying to curb. Again, we see huge investment in unhealthy food and drinks, less so on the healthy food. So we really need to be looking at how we can curb advertising. And issues such as the availability and density of fast food outlets and proximity to schools are all things that I know councils are concerned with and acting on. And then just another example around the importance of family, friends, and community to kind of address loneliness, give people a sense of belonging, and sort of relationships that can help them through challenges. And loneliness strongly associated with poorer mental health. And that also this relationship between low incomes and that kind of what that means for strain on family relationships. So there's, many of these building blocks are kind of, either negatively or positively reinforcing, and people who don't feel a sense of belonging in their neighbourhood, more likely to experience poor mental health. So again, the role that local government will often play in supporting neighbourhoods, absolutely vital to addressing some of these things. So kind of what are we doing about it? Well, two things. One, the partnership with CIPFA, which obviously you're going to hear more about later. But the other thing to bring your attention to is some work we're doing with Demos, looking at this concept of what if we had an expenditure limit on prevention. So alongside capital and revenue, we had a prevention departmental expenditure limit. Demos have been publishing a series of reports in partnership with us, exploring this concept. And I think it's encouraging that, we are getting engagement and interest in this concept. And I think last week, the NAO sort of spoke about the need to protect prevention spend in the NHS, for example. But of course, even if we have buy into this concept, the practicalities of how do you actually count and track prevention expenditure is a real challenge, and hence the reason why this work with CIPFA is so important. So just to kind of wrap up on that, I think, what I've set out is that there's avoidable differences in life expectancy and in healthy life expectancy, that where we live shapes our opportunities to be healthy, and therefore local government has this critical role to play, both in its formal sort of public health statutory responsibilities, but also in the wider services that local government and roles that it has in supporting communities. But of course, there are competing demands, urgent need on many local government budgets. We know that, and that makes it hard to protect prevention spend. So this piece of work, I think, in the first instance, saying, can we really count it and track it, is a real opportunity to progress this agenda of ensuring that ultimately we have more investment in prevention. So thank you for that, and I will stop sharing.
Great, thank you, Jo, and we'll come back to that after one more presentation from Paul Johnson, the Chief Exec of Public Health Scotland.
Thanks very much, Zach, and good afternoon, everyone. I'm afraid I'm a slightly disembodied voice because there's an issue with my Zoom. But the key thing is you're going to see my slides, I hope, and that's the most important thing rather than seeing me. But lovely to be here, and following immediately on from what Jo has said, I want to give you a perspective from Scotland, and be delighted to hear perspectives from across the UK in the course of this session. And I'm just going to ask Zach for you to move on as I go through the slides. So the next slide gives you a context, which is that we've known in Scotland for many, many years that we need to secure progress with preventative approaches in order to improve health and well-being. And Mike, look forward to hearing from you later with that particular perspective about great work that's underway in Glasgow just now. But many of you will have heard of the Christie Commission, which was seen really as a seminal work that set out the future for public services in Scotland back in 2011, and it made clear that prevention had to be at the heart of what we did. Following on from that, tackling health inequalities has been a focus for the Scottish Parliament, and recently we've been very glad to have the Health Foundation do a really significant report on health inequalities in Scotland, Leave No One Behind, and now to be working in partnership with Strathclyde University in the new Health Equity Research Unit, looking at how we can tackle inequalities better in Scotland. The next slide, though, gives you the stark picture of where we are at just now. And this is the one, colleagues, that I keep coming back to when I think about the work that's still ahead of us. Jo's video was great in setting out those two children and the 10-year potential gap in their life expectancy. And yet this graph looks at healthy life expectancy and is the one that I have to say stops me short. And it's the fact that for the healthy life expectancy of males in the 20% most deprived parts of Scotland, there is a 26-year gap in healthy life expectancy. For females, a 24.9-year gap. Another way of expressing that is that 1 million people in Scotland out of our approximate 5 million population will have a healthy life of less than 50 years. And when they are at the point where they are likely to be dying, their counterparts from the most well-off parts of Scotland will only be starting their period of ill health. So the gaps remain profound, but I don't want to be overly negative. The next slide sets out, in some ways, both the nature of the problem, but also begins to point to the hope that we can have that many of the issues are actually reversible. This shows, taken from the Chief Medical Officer in Scotland's most recent annual report, the proportion of people in Scotland who are affected by preventable risk factors. So keeping the focus, colleagues, on prevention, 67% of us are now experiencing obesity and overweight, much of which is preventable. And you can see the figures for those other categories of preventable harm. The next slide recognises that there is a very significant focus and a recognition of the need to tackle child poverty across the UK indeed, but it's been a particular focus of the government's work in Scotland. And again, we know that if we can make a significant dent in these poverty figures, then a great deal of progress will follow from it in terms of preventing the subsequent harm that poverty causes. But I'm afraid, despite the very good work that is underway in Scotland, such as the payment of Scottish Child Payment, an additional amount that's given to eligible families every week, we are still seeing the proportion of children living in persistent poverty as broadly static. So there remains much for us to do. The next slide looks specifically at what could happen in the years ahead. Now, Public Health Scotland has done a significant amount of work to project what is likely to happen with diseases in Scotland if current trends are not arrested. And I'm afraid there that our work demonstrates that we could be facing a 21% increase in the disease burden in Scotland over the next 18 years, 2/3 of which will be due to cancers, cardiovascular disease, and neurological conditions. The challenge for us is to interrupt that projected disease burden. And the possibility for us is that much of that disease burden could be prevented. And I think it's already been a theme of our webinar today that we know that prevention offers a return on investment. But the Journal of Epidemiology and Community Health calls it out with this greater level of granularity that prevention offers an ROI of at least £14 for every £1, and long term will perhaps be the only way in which we can ensure that our public services across the UK are sustainable. But the next slide just draws out a few examples from Scotland of areas where, certainly from a Public Health Scotland perspective, we can present really quite clear evidence around the success of preventative intervention. I'm keen, colleagues, that we do not lapse into what I think is slightly loose language, inferring that we're not doing prevention. We hear that quite a bit. We are. And indeed, preventative measures in health, such as vaccination, in Scotland, minimum unit pricing, our Child Smile programme, and indeed the UK-wide bans on smoking have had very significant impacts in a preventative space. Indeed, our relatively new HPV vaccine given to school-age children has had, from its initial research, phenomenal results in preventing cervical cancer in later years. So let's be clear, colleagues, that preventative investment works, and there are a range of areas where we can point quite specifically to the return on investment associated with it. I do appreciate, though, colleagues, we need to grapple with the fact that in some cases, it's harder to demonstrate the return on investment. And in some cases, we are struggling to identify areas of disinvestment in order that we can better invest in preventative interventions. I was really struck by the data that is known to many of you, I'm sure, on the next slide, coming from the Institute of Government, that shows patterns of local authority spending in England on children's services. And we're working to get similar data for Scotland. But I think it presents very clearly an overall picture whereby, due to pressures on public services, what we've seen over the last 15 years in general is a diminution in preventative expenditure and an increase in reactive and emergency expenditure. Now, I look forward to hearing whether that's something that you recognise in the various contexts that you work in. But if it is, then doesn't it just show how sharp an issue we have as we work to reverse the trends and trajectories that we have seen over the last 15 years across the UK? I'll pass quite quickly over the next slide because much of it has been touched on already in Joe's presentation about the range of areas of preventative investment where we, from a public health perspective, would want to see investment. And the reality is it's not only in one area. And maybe that's what lends some complexity to the issue and what perhaps makes our challenge even more difficult this afternoon, because we know that to improve the health and well-being of our citizens across the UK, we need to invest in both the social, the economic factors, the physical environment, high-quality, equitable health services, and we need to support people and create a climate where our health behaviours are more conducive to good health. What we call out in the boxes here, colleagues, are some specific examples of promising initiatives that we have identified in Scotland, and initiatives which we have recognised as vital to see protected given their preventative potential. And I'm more than happy to ask or to hear any other views on that. We're quite encouraged by the fact that in Scotland at the moment, as depicted on the next slide, there's significant work being done on a new population health framework. This is a co-production between the Scottish Government, local government, Scotland's Directors of Public Health, and Public Health Scotland. We recognise that there's a need to be truly intentional and long-term in our approach to improving the health of our nation. And we recognise, in line with the previous slide, that action is needed across the various domains of what makes for health and well-being. The evidence here is clear. We know that action is needed across these areas. But what we need is a system that is focused on prevention. Scottish Government has confirmed that this population health framework will be published in the coming weeks, and I do hope that we will be able to share it with all of you very soon. But of course, a framework is good, but what will be vital will be to see specific delivery in each of these domains with investment in the preventative interventions that will make a difference. A couple of final points before I finish off, colleagues. Within Public Health Scotland, we are speaking in particular to our NHS colleagues. The NHS in Scotland currently has a budget approaching £20 billion, which is a significant proportion of total Scottish expenditure. And we're advising there that for NHS colleagues, there's a need for action in three key preventative areas: the area of early years, of health care, and health harms. Now, I appreciate your priorities for prevention will differ depending on the sector or sectors in which you operate. But I do think that one of our challenges is to get a bit more granular around the types of support and the types of focused intervention that is needed as we take this work forward. My final couple of slides, the next one simply makes the point that in order for us to make progress with this issue, we need to bring the evidence to the table, and I've touched on some of that today, but we must also collaborate across our sectors, because much of the work that's needed to advance prevention is not capable of being done by one organisation or in one particular silo. It requires our partnerships. It requires a depth of data, bringing data from across our systems in real time. And of course, it requires careful monitoring so that we can demonstrate the impact of what we're doing. There are two particular partnerships that I wanted to share with you in closing, colleagues. The next slide sets out just a short summary of a very exciting partnership that Public Health Scotland, Edinburgh University and Police Scotland are taking forward at the new Edinburgh Futures Institute at the Scottish Prevention Hub. You can find out more about this if you just search Scottish Prevention Hub, Edinburgh University. But what we're trying to do there is come together across organisations, much as I've said earlier, bringing together our data, our place-based insights and our research, but really focusing on how can we lead? How can we lead in a way that is genuinely cross-sector and multi-sectoral in order to advance our work on prevention? And finally, we've got a really exciting new partnership with 3 local authority areas in Scotland that we'll be looking at very closely and seeking to advance prevention in. And the final slide introduces you to our partnership work with Aberdeen City, with South Lanarkshire and with North Ayrshire. We're working in collaboration with the Institute of Health Equity in these 3 areas, with a view to applying the 8 Marmot principles, which embed prevention into them, to see how we can support local improvement in those 3 areas alongside some of the national work that I've touched on as necessary. So in summary, colleagues, the challenge is stark. The health inequalities that we face are glaring. The future could be even more challenging if current trajectories continue, but we have opportunities to reverse current trends through both what we do and how we do it. Thanks very much. I look forward to hearing any questions and hope we can have some discussion about this. Thank you.
Great, thank you for that presentation, Paul. So I will pull my colleague Ellie Roy on screen, and we'd like to have a discussion with both presenters. So would encourage anyone who's watching to put your questions in the Q&A, which can be found at the bottom of your screens, and we can have a great discussion with our 2 speakers. So see the first question here in from Manny Ketley. Thank you for being the first, the brave one to submit a question forward. So a key contributor towards the reduction in spend on prevention is the pressure on public resources. What are your thoughts on enabling local government to levy a prevention precept that allows money to be ring-fenced solely for prevention use, much like the social care precept that social care local authorities are able to charge? So Joe, I think this sort of relates back to the work you were speaking about with Demos and their proposal for a new category of departmental expenditure limits. Don't know if you have any additional comments you'd like to make maybe on that work, or kind of more broadly to this idea of ring fencing spend for prevention.
Thank you for that. It's a really interesting idea, and I mean, one, I hadn't, it's not something I've heard come up in discussion that we've been having. So something I'd certainly like to take away and have a think about. I suppose just the one thought that comes to mind is, as you say, there's been the social care precept, and I don't know what the evidence is on how that's been actually deployed by councils. But of course, one of the things I guess with something like this is that there is always the risk that it could lead to more inequalities, in the sense that it's a sort of, if it's a down to local decision making, some places may do it, others not. We know obviously that inequalities are geographically patterned, but within councils there are still huge inequalities. So that would just be one thing I think kind of to consider. And the other thing kind of on that theme of just, is this money going to the right place in the first place? We've been funding some work with the IFS looking at the local government funding formula, of which, there is quite significant mismatch between what would be the sort of described need in a place relative to the funding that's flowing to that place. So I think it's a really interesting idea, and it's something that you could see being alongside sort of other steps that do ensure greater equity as well. But yeah, I'm going to take that away and talk to colleagues.
Yeah, great. Thank you, Joe. And perhaps building on the back of that, a question for Paul. So obviously public health responsibilities are slightly different in Scotland compared to England, where public health is a local responsibility. So just curious as to your thoughts around this idea of ring fencing spend for prevention as it relates to public health, sort of in your domain.
Thanks, Zach. So we've also been really interested in the Demos proposal around ring fence prevention expenditure, and indeed we've given evidence to the Scottish Parliament urging that the Parliament looks at that in more detail. They've picked that up and they've been engaging with Scottish Government on it, and we're continuing in our discussions with Scottish Government. It may well require UK-wide action. It would certainly be enabled and simplified by that by the UK, I think, adopting that third category of expenditure, prevention expenditure, alongside resource and capital. I think it could be difficult for it to be done at scale in a devolved nation without that UK support. But nonetheless, I suppose my one reservation about the earlier suggestion is that prevention needs to be at the heart of what we are spending our budgets on. And I think there's a risk, even with a separate category, that it's seen as an addition to core work rather than the core work. And I wonder how we can ensure, particularly those in leadership roles with responsibility for budget, that investing in prevention is recognised as core to the work. I appreciate the difficulties. In health, we see the challenges of the acute sector requiring resources and squeezing out some of that more preventative expenditure. But what I think we need to see, and what we are seeing in some areas, is that cross-sector leadership that's acting with real urgency and with determination to find new and more innovative ways to create prevention expenditure. The promise in Scotland, our mission to improve outcomes for care experienced children and young people, is one area where we're seeking to take forward preventative action on a cross-sectoral basis.
Great, thank you, Paul. I think interesting point you made there around seeing some of these preventative activities as additional to the core work that councils are doing. We're certainly finding that with the councils that we're working with on our project at CITFA, that a lot of the service providers' everyday roles are actually closely connected to prevention, but that connection isn't always clear to everyone. So, Joe, I'm just curious to sort of bring this back to you about some of the work that the Health Foundation is doing to not only advance the thinking around the building blocks of health, but to help see that embedded in working around the country. I'm not sure if you have anything to add on that point.
Yeah, I mean, so maybe to reference a couple of things that we're doing. One is we have published quite few reports looking at the role local government can play in terms of trying to curb the exposure local populations have to sort of risk factors to health, whether it's things around, tobacco, alcohol, and fast food, and the powers that they have around planning, licensing, advertising, and so on. So if you go to our website, we do have some sort of quite practical resources saying these are the things that are within existing powers of local government to try and act on some of these known risk factors. The other thing that we've been doing as well is saying, and this is what local government could do more in this space if nationally there were some more powers made available to local government. So that's one area where we've been advocating quite hard around the powers that local government need on curbing exposure to risk factors. The other work that we're doing is around working age health. So we have a report which will be coming out in the next month that is looking at what's happening with working age health, and in particular the role that employers and the welfare system can play in helping people, as we saw from the data before from Paul, the reality is people are living with more ill health earlier in life. And that's something that we've got to be thinking about, how the working environment is adapted to support people stay and work for longer because of the sort of obvious help that provides in terms of income, purpose, connection, community, and so on. So, we think this is another area where some action is possible at the moment, because I think there's a receptivity sort of nationally in government recognising these challenges around health and workplace.
Yeah, thank you for that, Joe. I think there certainly has been a change in discourse around prevention, certainly at the national level, with this new government. I know many of us are excited to see what will be in the 10-year plan and sort of subsequent decisions that are made later. I think a lot of that discourse has been focused around sort of individual behavior change or more medicalized interventions. So Paul and then maybe Joe after that, I'm just curious as to your thoughts on how we can balance the approach to improving health, both at an individual level, but also at the community level, thinking about those building blocks of health and what we can do to sort of improve resilience broadly.
Yeah, thanks, Zach. I like the way in which you framed the question. You've used the word balance, and I think it's important from a public health perspective that we don't suggest that improving health is all about environmental factors. Though I think the evidence points to the dominant role that those factors, those broader social, economic, and environmental factors need to play. So we do need to support individuals to make good choices with regard to their own health. And so, for example, making vaccination and screening really easy, straightforward, and accessible to all is one area where we can support individuals to take sensible steps that will help their own health. But let me touch just briefly on the issue of food and obesity. It was the largest risk factor in the material that I shared in the presentation earlier. And in Public Health Scotland, we've been particularly struck by the recent work that Nesta have put forward around their blueprint for tackling obesity. And again, I like the fact that it sets out the need for a balanced package of measures. There are lots of choices for policymakers, but the Nesta work does show that it's through preventative action and particularly changing the food environment that we can, in all likelihood, see the greatest impact for our investment of public funds. So in particular, making sure, as Joe touched on, that healthy food is accessible and reasonable for more of our citizens. And Nesta in particular point to, for example, a healthiness target for large retailers, which I think is really worth further exploration. There are ways in which we can seek to come up with that balanced package of policy interventions that will keep the focus on the social, economic, and environmental factors while supporting individuals to be empowered in terms of making good choices around their own health. Thanks.
Yeah, that's great, Paul. I've often heard it described as sort of a soundboard with different volume dials. And so if an individual can kind of lower the volume of risk in some through certain actions, then that's really great. But if you see those other dials, the environmental factors, as you mentioned, unhealthy food and so on, then the overall volume, the overall risk can be really difficult to address. And so if we can kind of address those other areas, the environmental factors, the social factors, the economic factors, and enable people to make healthier decisions to lower that risk volume, then that's what we ought to do, I suppose, as policy makers. So Joe, maybe I'll just pass it over to you for a comment. I don't know if you have anything to add to that point there.
Yeah, I mean, certainly agree with everything Paul said. And I think kind of in a way, well, your dashboard analogy sort of illustrates the challenge that I think we often have when we're trying to make the case for preventative action, because in a sense, no one single thing, works on its own. It's not like finding the vaccine or the medication that's going to sort of treat a particular condition. And I think that can be very challenging for decision makers, because they're trying to balance a whole range of demands and pressures, and they want to know, well, what's the thing that's going to work, and ultimately it's a combination of all these things. And in a sense we know that from our own lives, because those of us that have secure work, good income, good quality, it's all those multiple, it's all those small things, small advantages and sometimes big advantages that are all building up, and adding together cumulatively to give us those opportunities to be healthy. And if you're, in a different set of circumstances, it's the cumulative small disadvantages or, sort of lack of opportunity. So it is challenging, this, I think, and that's why ultimately we need to find a way of being able to tackle this on multiple fronts, I think.
Yeah, for sure. I think the Health Foundation's imagery of the building blocks of health is really useful there. If you remove one block, then that tower kind of becomes unstable. But as you remove more and more, you see that it's so easy for things to fall apart really quickly. So a really valuable tool there, I think. We have a few more minutes this session. I see a few more questions and comments coming through. We have one here around addressing the commercial determinants of health. Good work on prevention can be adversely impacted by these factors. Not sure. Yeah, Paul, maybe we can start with you
I'm
if you have
happy to come in on that.
thoughts around
Yeah,
the
can I just thank
determinants.
can I thank for that really interesting BMJ link? I was just scanning that. They're fascinating to see the tactics that McDonald's have utilized in terms of planning. So I agree, this is a vital area. I made reference to health harms. Within Scotland, we've had a real focus on addressing harm from tobacco. And in fact, we're now doing that across the UK, really supporting the age-restricted tobacco ban. Good to see action on vaping. And we're really proud of the work we've done in Scotland on minimum unit pricing for alcohol. We did a 5-year research and evaluation of that in Public Health Scotland, and we are clear that the estimated reductions in hospitalisation and death present a compelling case for that to be introduced across the UK. And I do hope there are some here who might be able to progress action. Let's be really clear, though. Every time we propose action in relation to the commercial determinants of health, it faces strenuous resistance from the industries that will be impacted by these items. And there is a urgent need from a public health perspective for us to work together to ensure that we can take preventative action, albeit with rigorous evaluation and monitoring and with the prospect of changing if it doesn't work. But I think there's a preventative principle that needs to apply that means that where we can see that preventable harm is being done to human health, then we will take forward action. Of course, its implementation needs to be done very much in partnership with the industry. And I think while significant action has been taken on tobacco and alcohol, the reality is we've not done anywhere near as much as we need to do on unhealthy food. And that remains a challenge that governments nationally and locally need to address. But I appreciate from the BMJ point that there are local authorities working tirelessly to address, for example, the rollout of further fast food outlets in the area. And I think that's where I come back to Nesta's work as providing some very specific policy options that would help us with some of the national approaches that are needed there.
Yeah, I suppose that points to this idea that really all of these things are connected, and it's not only up to local government to advance the prevention conversation and practice, it's really a shared responsibility, I suppose. So managing those private interests and competing priorities can be difficult, but I suppose the benefits of good health are shared across, all of society in the long run. So definitely an area to keep watching. Ellie, maybe I'll pass the floor over to you if you have any final comments or questions that you'd like to raise with the presenters today.
So there's been a couple of further questions in the chat relating to the suggestion of a prevention precept that I maybe won't answer in full. Apologies to those who've asked them, but just a couple of issues that I would like to touch on. So I feel it's probably remiss if I don't mention the fact that council tax is not the most progressive form of taxation. And as we see with the social care precept, those areas that are able to raise the most through that mechanism are perhaps not those that need the funding the most. So there's no perfect system, but I can see a few issues around a prevention precept. But one of the questions in the chat raises the issue of a definition of preventative spend, and the question being how would we define it, just to prevent people redefining existing spend. Now you're going to hear a little bit more from Zach later in detail about the work that we're doing with Health Foundation in order to try and identify local government spend on prevention, and defining what we mean by prevention has been one of the biggest challenges that we have faced in doing that. We knew it would be, and we suspected that's why nobody has tried to do this work before. So that is an absolute key element. And to touch on the point about redefining existing spend, part of the reason I was really keen to take this work forward is that, as Joe's pointed out, with the building blocks of health, a lot of what local government does impacts on those building blocks. And therefore, my suspicion is that a lot of spend on local government services can be classified as preventative already. And we'd like to shine a light on that to enable them to see how much of what they do is preventative, and to then make those decisions about whether they should be doing more of that, whether they should be doing something different. If we have a couple of minutes left, but as you can tell from my accent, I'm also a Scot, and Paul has just petrified me by pointing out that the healthy life expectancy in Scotland, I can expect an average of 50 years healthy life expectancy. I'm around that age, so I'm terrified. But I would like to ask Paul, you recognise the importance of cross-sector collaboration, and in Scotland we've had a bit of a more integrated system since 2014 with the health and social care partnerships, whereas south of the border that's only been in place really for a couple of years on a statutory basis. So Paul, I just wondered if you have a view as to whether you think that's been helpful in taking forward the work on prevention, particularly across that boundary of NHS and local government.
Oh, Ellie, that's a challenging final question for me, isn't it? You always get the difficult question at the end, don't you? I think Mike might be better placed to speak about that one when he comes in. I have to say, when I look at the situation just now, though, I'm going to be absolutely clear. I'm sorry, I'm getting a bit of an echo. I don't know if somebody else needs to mute. But when I look at the situation overall, I'm really concerned about whether health and social care partnerships and IGBs are managing to prioritise prevention at the moment. Because what I'm seeing and hearing is the cutting of quite a lot of preventative interventions, if I'm going to be really blunt. And I appreciate that that is happening because of constrained financial contexts, and in an attempt, for example, to address delayed discharges in hospitals, there's a focus more on social care places than on perhaps preventative interventions such as, say, income maximisation. I'm not pretending this is easy, but if your question is, does the health and social care partnership model help move us forward on prevention? I'd say I'm not convinced that it does just as a model. I think it has to come back to ways of working, to leadership, of course, to effective funding. But I'm afraid at the moment I see huge challenges in terms of whether the HSCPs themselves are truly prioritising prevention activity. I hope we'll see that change. and very happy to learn more about that and indeed to work with those health and social care partnerships to see how we can secure progress.
I think we're seeing that across the entirety of the UK, the acute pressures at the moment. So front and centre that they take up all the focus and all the bandwidth. Thank you.
All right. Well, with that, that brings us to the end of this first session. So I'd just like to thank Joe and Paul for joining us today, for sharing your insights on prevention and the building blocks of health. We will now have a short 10-minute break, and we'll come back at 2:10 p.m., so in 10 minutes, for session 2, looking at the barriers to adopting a preventative approach. So go and grab a cup of tea, and we'll see you back in 10 minutes. This next session looks at barriers to adopting a preventative approach. Sometimes it's the most obvious solutions that fail to materialize, but why is this? And in the case of prevention, what can we do to overcome some of the barriers? I'm joined by Jim McManus, National Director of Health and Wellbeing at Public Health Wales, and Mike Burns, Programme Director, Child Poverty and Prevention at Glasgow City Council, who will share their insights from Wales and Scotland, respectively. So Jim, I think you're up first, if you'd like to share.
Deal, thank you. I'm just going to try and share my screen. Can you see that?
Yeah, that looks great.
Great. So, Bryn our colleagues, good afternoon. I'm Jim McManus Dewey from Iechyd Cyhoeddus Cymru, Public Health Wales. You're welcome to have these slides because I'm going to run through them rather than go in detail through them. This slide back represents a little bit of some of the work we've been doing in Wales and some of the work I've been doing on why prevention fails. As Paul said, of course we're doing preventive work, but my focus is that firstly we need to do more, and secondly we need to make it as effective as possible, and thirdly we actually need to demonstrate its value. And it seems to me that we need to move beyond just return on investment in prevention and get into mapping and articulating the benefits to the system and to the agencies of preventive efforts. So I've looked nationally and internationally at why prevention fails, and I'm going to share some of that learning that I've had this afternoon with you. In Wales, we are doing quite a lot of prevalence of disease work, which was the spur to one of the programmes, the national programmes I'm going to talk about in a minute, and a 10-year look. And it emphasises, I think, what colleagues in Scotland have said. We are looking down the barrel of declines in healthy life expectancy and significant levels of preventive disease. So what Joe said about the UK and Paul said about Scotland applies to us as well. And of course, in Wales, we've got the Future Generation of Wales Act, which specifies not just the prevention obligation, but actually principles of working for the whole system that I think are really good. It's one of the things that attracted me to work in Wales. Now, we've known for years, actually, that local government is a crucial preventive service. I would argue we've known since the Public Health Act 1936, in fact, the Public Health Act 1848, which had parks as a public health outcome. And if you look at any textbook of public health published before 1930, it will talk about things local government does all across the UK, including parks. So we know the power of municipalities. One of the things we have in Wales is a programme called Shaping Places for Healthier Wales, which is jointly run with the Health Foundation, where we've engaged every single public service board in Wales on identifying a route map of how they can impact. So I'm going to come on to some of the stuff we're doing. We've just published a document called Investing in a Healthier Wales, which is our Prioritising Prevention, which is, if you like, our view of best buys from conception to grave on prevention. And at the other end of the scale, we are present in every school in Wales through mental health work and through our wellbeing work and our physical activity and school wellbeing and nutrition work. And we're currently consulting on bringing all that together under one framework. So there is a lot going on. But why doesn't prevention get much more traction? Why doesn't prevention work and deliver for us? I'm a skeptic about whether prevention will ever cash a check for you. But I think there are 17 reasons, and there'll be an exam at the end of this, why prevention fails. I'm not going to go through all of them, but I've divided them into 4 groups. One is the wrong mindset. So you have sloppy language about what prevention is. Another is actually you've got the wrong policy or authorising environment. And Australia does great work on understanding the authorising environment for public services, and I wish we would copy it. You've got the wrong setup, so the wrong leadership or the wrong disciplines. No behavioural sciences, for example, and I'll come back to that in a minute. Or you've got the wrong phasing, or you've just got the wrong implementation. You haven't actually worked out that to make a difference, you need to take an intervention at population level and you're applying it to individuals or vice versa. You've also got what I call now the bored now factor of people just get bored and there is no staying power. So these reasons are all very well evidenced in evaluation reports and the literature on why prevention fails. And I think it is possible to build in prevention design that stops these lessons derailing you. And I'm going to say a little bit about discipline. So that's one set of why prevention fails. Another is because you use the wrong disciplines. We knew in vaccination and COVID that local authorities had capabilities way beyond the NHS. And we also saw the importance of behavioural sciences. And I think we do badly in the UK at integrating behavioural sciences into prevention practice. One of the reasons why I helped set up a national charity called the Behavioural Science and Public Health Network. The website has tools and resources for professionals, including tools for local authorities wanting to employ behavioural science people. Our conference is coming up. Have a look at the website and you'll find some free things that will probably help you use behavioural sciences better. And in Wales, we've also got a guide on how to use behavioural science in policy and practice. So I think prevention always has to work across disciplines, and it has to be transdisciplinary in that it needs to take different disciplines and work them together into a solution. And if you don't do that, that is one of the reasons you are more likely to fail. I think we need to work out why and when prevention is worth a candle. You're not usually going to clash a check from prevention efforts, I have to say. It's not going to really help you. So how do you measure them tangibly, and how do you get into the benefits of prevention? This model here from Newcastle University actually talks about innovation in health and care, but it's a really good idea of how you map the benefits of prevention. So if you are going to do secondary prevention, for example, of people with diabetes to avoid hospital admissions, mapping the benefits and being clear about what they are and who they come to is actually far more important, I think, than talking about cashing a check, because there will be wide benefits and some of them won't be worth the effort. You wouldn't do a program without mapping the benefits. Why do we do prevention without mapping benefits? Moving on, I do think you need a strategic landscape for prevention to work, and it needs policies and budgets which are prevention proofed. So we need government to realise that prevention is in its own enlightened self-interest. We also need, I think, service design which is configured to enable prevention by default, not as an add-on the end, which takes us back to the old public health tool of pathways. If you want to stop people deconditioning after hospital, you need to build in things that stop them deconditioning while they're in hospital. It needs to be built into the pathway. And some of the lack of strategic landscape or an authorising environment or behavioural sciences or the wrong discipline, or those 17 factors are the reasons prevention fails. I think the other reason prevention fails is we have really sloppy language about what we're talking about. Is it primary prevention? We're trying to stop something in the first place, in which case are we looking at wider determinants, such as built environment or air quality, or are we looking at psychosocial determinants, such as whether people feel safe in the workplace? Are we looking at behavioural determinants like diet, or are we looking at secondary and tertiary prevention? We need to be clear. because with lack of clarity comes confusion. And I'm sure we've all read that famous article in the Harvard Business Review about confusion brings failure. I'm not going to go through this in detail, but you need building blocks of a shift to prevention. I loved the slide Paul shared. I hope we are able to steal that with pride, share it with love, and shamelessly roll this out across every other nation in the UK. For me, one of the things we're trying to do in Wales is build a strategic shift to prevention. That means we have to build system capabilities to deliver it. We have to build the right interventions, the right programs. We need a strategic approach to which channels we use. And that needs us to be very organized and very systematized and take a program management approach. As of 2023, 46% of adults in Wales have one or more long-term conditions. By 2035, we expect potentially, if nothing changes, 1 in 11 adults in Wales to have type 2 diabetes, which is preventable. We cannot afford not to prevent, because we won't have an NHS, and we won't have a social care system, and we won't have an economy. We can't compete with China if our population is too ill to go to work. That much should be self-evident. So I want to talk you through in Wales some of the things we are trying to do, using one example to design prevention for success. And at least if we fail, we'll know why we've failed. We have a thing called the All Wales Diabetes Prevention Programme, which is good, but much more is needed. We've got evaluations of that. Actually, we're looking at a digital model of it. It rolls out across Wales to stop people moving from pre-diabetes to type 2. Not enough of it. We're looking at remission and other things. But in and of itself, this is not going to turn the tide of our disease projections. And these are our disease projections. This graph shows that if the current trend goes as it goes in Wales, 8% of the Welsh population will have diabetes by 2035. That's nearly a 50% increase in the prevalence of type 2 diabetes. We already spend 10% of the NHS diabetes in Wales on 10% of the NHS budget on Wales in diabetes. We can't afford to spend 20. So this is a bit of a burning platform for us. So our case for change is that actually we're already paying the cost of not preventing disease and demand. It's not a case of it's a nice to have, it's a case of if we don't do it, we will be in real trouble. And Wanless told us that for the UK in 2002. So if a person with diabetes is admitted to hospital, there's an 8% chance they'll die in a year. And that rises to 13% if they have an amputation. We've done the calculations, and we estimate conservatively we spend around 425 million on hospital pathways alone in diabetes before we include primary care, and 92.3 million pounds on drugs. Imagine if that were to double by 2035. The impact of that on our budget could become 20% of the Welsh budget. We can't afford that, and we're already paying the costs. So we've created a programme called Tackling Diabetes Together, and our aim is to do two things. Bring about a step change in diabetes management and prevention all across Wales. And to do that, we have an objective to have more people living well with diabetes, type 1 and 2, by 28-29, and have stopped the prevalence of type 2 diabetes rising by the end of 28-29. That's ambitious. I'm the SRO for it. So if I'm not here in 3 years' time, I've had my P45. But in our first year, we've identified a number of successes. We've got the bundle of 8 performance for 8 care processes now as a must-do for all health systems in Wales. We have an engagement ecology with people living with diabetes, which is looking to empower them to do self-management and spread that across Wales. We've actually done some behavioural science work that looks at how professionals stop prevention happening. Because most behavioural science and prevention seems to spend its time looking at patients and people, not professionals. And actually, we are part of the problem. as well as part of the solution, and a range of other things. We're trying to make a complex system change, and we're focusing on high impact interventions and the system connectivity. But one of the things that we are trying to learn the lesson of is actually working to deliver prevention in a complex system means you need to get the system conditions right. And so an awful lot of work needs to go into not just the case for change, but establishing those system conditions, which is where we are now, before you can move to system delivery. Now, this sounds like it's blindingly obvious. And if you've done a lot of program management, then it becomes so. But actually, a lot of prevention work doesn't take that on board, because we don't give it the seriousness with which we plan service rollouts, for example. And I think that's because our mindset around prevention is often too simplistic. So this nice, intuitive, simple little diagram is our roadmap, if you like, to the golden sunrise of the step change in 2028, and a range of programs across high impact interventions. And you'll see we've phased them and we've layered them across clinical services. So down the outside, we've layered them, we've phased them. That is basically our program plan on a page for where we're going to over the next 4 years of work to get to the 1st of April 2029. And there's a range of things, some of which are already there. And there's a range of things across primary prevention, but you'll see an awful lot is in secondary and tertiary, because that's the area that will give us the yield and the benefit in the short term. So where from here? I think, firstly, learning to fail well is going to be vital. And the thing we don't do in prevention too much is learn to fail well. And what do I mean by that? Well, a colleague of mine in Public Health Wales, Ian Bell, who's running our prevalence of disease programme, talks about failing well. And that's about understanding why you fail, building contingency, building learning, apply that learning to the next stage. I don't think we do that to prevention in the way that we do in health quality and health quality sciences. The second thing is we need to learn more about implementation. Apparently implementation science is a science now. I used to call it getting things done. But we need to do much more about implementation science. And the This Institute in Cambridge has a series of free open access guides on elements of implementation science and healthcare quality that are very applicable to prevention. You need to get the basics right before you get off the starting blocks. And too often with prevention, we don't do that. We need to be systematic and articulate the why. And I think finally, we need navigators, not boffins. What do I mean by that? Well, I think the prevention landscape is full of people who will tell us what the problems are. What they don't articulate is what the solutions are, what the actions are, the impact, the benefits, and how to get there. And that's where we need to move to next. Now, we can do this. We've done it in HIV for over 40 years. We've done it in type 1 diabetes. We've done it in a range of other things. There is absolutely no reason we can't. So the key thing about prevention and the key message is do not get despondent, get organised and systematic. You're welcome to these slides. Happy to stop there and answer any questions. And thank you very much for listening.
Great. Thank you very much, Jim. Just looking at time, I'll pass things on really quickly to Mike, and then we'll leave a few minutes at the end for some questions, but definitely left us with a lot to think about.
Thank you. Just hold on, I'll bring up this. Zach, are you able to bring up the slides? I'm having some IT problems at the moment.
Yes, of course. Yeah, that's fine.
Okay. Apologies. I've also got a bit of internet connection problem, so I'm just going to keep going, Zach, and hopefully I'll come in due course. Invariably, when I think you're asked to do a presentation like this, you're concentrating on your own presentation and doing the presentation, but I've been immensely struck by the introduction from yourself, Zach, and also the other contributors. I think the bit about recognising that there needs to be a shift to prevention now, I mean, and the fierce urgency that I think Jim, Paul and Joe have captured about the issues in and about kind of the social capital, the need to get granular. I think Jim's analysis is absolutely superb in terms of the insights, and I'll certainly be using your slides, Jim, in terms of the next stages of what it is. But hopefully I can also provide a bit of insight into what we've tried to do in Glasgow. And I think the point that you've made, Jim, about beginning to understand failing. I've failed spectacularly in my career, over 40 years within social work, standing in the wrong place, looking at the problem through the wrong lens and utilising the wrong tools. And I think your bit about actually engaging in what it is that we need to do differently becomes absolutely critical. Next slide, thanks. Similar to Jim, I'm not going to go through all of these slides because I think we've covered a number of issues on it. And what I would say to people again is I'm more than happy for them to be shared. But in terms of headlines, I've tried to think of this presentation through that financial perspective. And I think the point that Zach made about the fact that the public finances are just utterly unsustainable. But what you've got, and I think Jim touched on it, is a whole set of legacy systems. I call it the power of the as-is system. And that bit that Jim touched on is about the need to really focus in on the enabling context and culture. And that was something that we deployed Celsius, and we deployed every stakeholder. So I think Paul made reference to engaging other parts of the system like Scottish Government, like Glasgow Council, but also health, third sector, police, to get that deeper understanding and an analysis of the as-is system. What is it doing well, but what is it fundamentally failing to see? And I think the bit that when we did the implementation science, we recognised that people did not like the term slowing down with precision to create the context for change. So one of the things that we did do, Jim, is we started to use implementation science. We started to talk about why does collective and distributive leadership become important? Because what you're doing is you're connecting the reality on the ground with what you think is happening strategically, and you're getting into the granular. One of the things that I say, whether it's in local government or health, organisations by and large do not value thinking. They value action and they value activity. And one of the things that we started to get into, and I think Jim touched on it again, is the bit about saying, if it's a legacy system and everybody nods their head to it, then you need capacity to change a complex system. It is not going to change by itself. And consequently, you need to create that container about moving from risk to a transition into a new world. And one of the things I came across was this issue about saying organisations completely overestimate what they can do in a year, but they completely underestimate what they can do in 5. So that bit about saying a real need to attend to readiness, alignment and cohesion. Next slide. In terms of our particular analysis within Glasgow, Paul made reference to the Christie Commission about moving away from failure demand and getting into primary prevention. And we thought to ourselves, could we be a workforce? Could we be a leadership that did that? And when we looked at some of the work that we've done in relation to child poverty alone in the city of Glasgow, we reckon is costing somewhere between 800 million to 1.9 billion a year only on child poverty. And when we looked at that, initially you kind of take an intake and breath, but when we've been looking at this, we're thinking that that's a significant underestimation. And one of the things that we've tried to get the system to attend to is the fact that the most important infrastructure in the city, we say to the politicians, isn't IT, isn't roads, isn't potholes. The most important infrastructure is family. So in terms of that, moving on, Zach, that one of the things that we started to then focus in on was about saying we utilised this research by Professor Paul Bywater for Huddersfield University, who was pointing us to the fact that although you looked at the number of children in care, what he was saying to us is the research has shown us that we are overcommitting to children coming into care from the poorest areas. And when we looked at that, if you look at that graph in relation to Scotland, it's showing you that 233 kids per 10,000 is coming into care at a rate of knots. And we knew that within Glasgow, we were generating somewhere in the region of 135 kids coming into care per 10,000. You'll notice, similar to Belfast and Northern Ireland, that Northern Ireland were doing something very different at 56. And that was something that we were appalled by and shocked by. Next slide, probably, again, I think Zach and other people have touched on this. Believe it or not, but this took a year to do, was to put together the financial mechanism of an integrated, and I know the question was asked to Paul about, being in an integrated setting, and I'll say something about that, because I think when you integrate in one area, you potentially disintegrate in another. And if it's whole system, it needs to be whole system. But when we put this graph together 10 years ago, we said budget of 166 million, of which we were spending 95 million pounds on care. And believe it or not, we were spending 42.3 million pounds a year on 239 kids. And if you got those 239 kids into a room, they would be both staggered by the figure, but they would also then be hugely angry. Because if you look at the educare and the preventative element, what it showed us in Glasgow, that within the Health and Social Care Partnership, we were spending nothing on prevention, and we were spending an eye-watering, unsustainable amount on care. And we thought, we either continue to do this, Jim's point, Paul's point, or we get with the project. And one of the things that we recognised was that when we looked at the data of outcomes, we made that reference earlier on, is that 2/3, 65% of the kids that were taken into care, where were they going once they'd been in care? They were going home. And that's an appalling level of performance in relation to your target and what it is that you're doing, because we're taking too many kids into care too late. And we decided 10 years ago, could we significantly shift that? Next slide, Zach, thanks. So in terms of that, one of the things that we started to really identify, and I think it was touched on earlier, is that our system was overly focused in on risk. It was a child protection system that was risk focused, that basically we created bureaucratic assessment process to strengthen and identify the risk, but also a lot of the time to protect the organisation. And where we shifted it to was a system that was promoting positive good news stories, that we really started to involve families. We did a family support strategy with 80 families. We did an integrated family system, integrated children's plan, with 1,325 voices. And what families told us, similar to Paul's reference to the promise, they told us they wanted better early help, and they wanted early help when they needed it, not an extreme form, an acute level of care too late. So Moose came back to see us. He kind of noted the fact that we'd, in a sense, really strengthened this anti-poverty, looking at family support, taking a much more strength-based, trauma-informed view of moving the system to much more early help and earlier intervention. I don't know if that slide's moved on or if you've lost me for a moment, Zach. There it is. So one of the things that we were indicating was that not only had we massively reduced the number of children in care by over 500, but we had a remarkable spin-off of much greater placement stability, because we recognised that services were too focused on risk and removal and not enough on long-term outcomes that children wanted with their families. Next slide, Zach, thanks. So one of the things that we started to focus in on, I think, is a different way of kind of reference some of the points that Joe, Paul and Jim have made about too many funding shortfalls, fragmented policy, families saying that intervening in Glasgow is too complex a system, and also recognising that we needed, or even employing community connectors to help people to navigate through the system. How crazy is that? That you're actually employing people to help families to get the help they need when they need it. So one of the things that we started to look at was to say, can we make early help and earlier intervention more accessible, easier, quicker and earlier. Thanks, Zach. Next slide. So one of the things that we started to focus in on was the fact that the system, and I think, Jim, you touched on this, that the system is utterly chaotic. You made the point, which I wrote down, was about saying more BA pilots, too many strategies, too many policies, and everybody's working really hard. There's no doubt about that. But in actual fact, it's Jim's point about a lack of attention to where is the leverage in the system, where is the moments of intervention that can have a leveragey change that's significant and different. And that's something that you're then bringing people together to go. And I like the point that you were raising, Jim. I was getting frustrated this morning because I was talking to somebody about early years and earlier intervention. We love to talk about it. We love to write about it. We love to research it. We love to write policies about it. But my God, try and get into a position of a strategy that's focused on impact to a child in Carlton, in Possil, in Castle Milk. Different ballgame. Next slide. So this kind of just touches on, I think, the point that Seng's making is we're too often looking at the snapshots of the system without getting into the deeper level. Thanks, Zach. So opportunities is about aligning funding, which I think, again, Paul made the point. I'll just go to the final bullet point on that, because in terms of those earlier questions, Zach, we've tried to do this in Glasgow. We've tried to take an approach which was to take whole family wellbeing fund money for the government, connect it into employability, no one left behind, connect it into child poverty, and connect it into other funding flexes to say, could you get that funding to become much more robust and then much more focused in on the leverage? Thanks. Next bullet point. Sorry, next slide. So I'm not going to go through these slides, but one of the things, just clicking on them, Zach, is we've gone from a really kind of a shift from talking to listening, really going from hierarchical, where we're saying you could spend all of your time on activities, meetings and emails, but in a sense where you've got to shift your leadership to, on the other side of the page, is much more in a sense, if you click on these, Zach, they'll bring up the bit in relation to much more collective, much more about analysis, exploration, all of the points that Jim's making we did in Glasgow. So every Thursday afternoon, Jim, we would get into reflection and deep thinking, curious about the data, drilling the data down into Carlton, being thoughtful and precise, listening to dissent, but always actually trying to move together. Thanks. Next slide. I'll move some of these on. If you want to move these slides on, I'll send these out to people. But and again, this is about leverage, moving a kind of culture and paradigm away from looking at workforce structure and workforce numbers, actually saying you need a cultural shift. Next slide, Zach. Next slide. So one of the things that we're in conversation with, and I will follow up a conversation with Paul, but Paul and I are both in a conversation where we're trying to take the Scottish Government activity at the top end and really drill it down to those families' touch points and services, and actually have a feedback loop that is about the reality of family experience and influence families' needs. Next slide. Move on for that slide, because that probably gives you a sense of the strengths-based, trauma-informed, and that's available to people. But one of the things that we've done here, I'll just again touch on a couple of points, is working in an integrated system. We gave our health visitors that we had responsibility for, we gave them access to cash first. And instead of the health visitor referring to social work, we gave them early help. We gave them permissions to do early help to help families. And again, that was critically came through in relation to COVID. Next slide. So you'll see that some of the gains that we've made, we got money for Scottish Government that we went during COVID. We put 3.3 million directly into supporting families. And instead of going for 32 admissions a month to children coming into care, we had one. And what we've also then started to do, just as we're highlighting there again, if people want to come back to me on the detail of this, do. Next slide. Zach, I'm conscious of time. So there is where we've landed in Glasgow. We started off 10 years ago with 1,413 children in care, costing us that 95 million. And we've gone down to currently, today's number is 570. We've reduced, we're nearly at 900 less children in care. And it picks up Jim and Paul and Joe's point about we would have been unsustainable. We would have been financially bust like other local authorities had we not done what we've done. Next couple of slides, Zach, I'll fire through these really quickly. This kind of echoes a lot of the points that's been made by Jim. I'm not going to go through that, but too many strategies and the mindset to focus positionally, Jim. So we're even seeing that. It's like, I really like breaking that word, like the mind is set. We're standing on the position, and that gets into a lot of positional power about protecting annual budgets and the annual budgets, and we need to look at that differently. Zach, just keep moving these on so that I'll get finished the next couple of minutes. So, you know, that bit, again, I would point people to, of those 569 kids in care now, only 94 of them are under 5, which I think is a massive seismic shift. That we've secured savings well over 32 million. And again, had we have those same number of kids in care, it would be costing us 70 million. And I think people have made the point, again, keen to chat about it, Zach, is to say that we've started to, you saw that 2.7 million, that wee bit of yellow, but in actual fact, when you start hunting down the community fund, when you start hunting down other government money, I think there's circa 106 million that could be in prevention rather than just that 2.7 million. Next couple of, I think I'm hoping these slides finish out. These are some of the questions that we need to look at. And I think Jim's done a bit about, we need to get deliberate and intentional about defining prevention and early help. And again, Jim, that's come out of research that Celsius has done in relation to children's services. And we need to engage the voice of lived experience better. We need a different approach to collective leadership, because it picks up Paul's point. It's got to be between Scottish Government, health, the council, right the way down to that local bit. And it's about what are we learning as we go. So thanks very much. Apologies, that's a bit of a rush, but hopefully gives you a sense of how we've tried to take some of that strategic intent and the impact that it can have.
Great. Thank you very much, Mike. I think it's been really interesting to see, you know, Jim's perspective working centrally in Wales, and then Mike's perspective working locally in Scotland, but facing a lot of the same barriers, and certainly coming up with some potential solutions that I think are relevant regardless of where you are, and likely outside of the UK as well. So really, really great presentations there. We've got a few questions and comments coming through in the Q&A. Jim, I see you flagged one. Would you like to start with that? So the comment is on community pharmacies often being located in the most deprived communities, heavily supporting the prevention agenda. How can they be used to target other prevention pathways such as dental care and so on? You wanted to comment on that.
I think community pharmacies are massively underused and a massively underexploited opportunity for health gain. When I worked in England, one of the things I was conscious of is that directors of public health could commission community pharmacies, and I did in my area, but actually our budget was tiny, whereas the commissioning of them by the NHS was patchy and piecemeal for direct things and enhanced services. And the best areas were those where the NHS, nationally, locally, and the Director of Public Health joined up to create a spec that was jointly commissioned for pharmacy. I think pharmacies could do a huge range of things. I've seen them do great work in diabetes. I've seen them do great work in heart disease, even minor ailments and infections. They do take work off GPs, but there's also something around, going back to something that Mike said about, a system that enables families to take care of their children. I absolutely love that. I have seen pharmacists, just by their style, empower very, very scared and frightened parents about the health of their children. So we mustn't forget that you know, all of the psychology we know around patient professional interaction says that how a professional interacts is every bit as important for some people as what they do. And community pharmacists have got that by the bucket load. So community pharmacists get my vote of things that they could do, and we massively underuse them as a resource. A bit like local authority leisure staff, massively underuse them as a resource, I think.
Yeah, I think that threads back to the conversation we were having in the earlier session around sort of this shared responsibility of prevention, and that it really does need to be delivered by all different aspects of not only the sort of medical and health and social care communities, but broadly share across public services. I've called my colleague back up on screen, Ellie Roy. Ellie, I don't know if you have any other questions that you'd like to bring up with the speakers. I'm just having a look through the Q&A, but if you have anything to add.
And thanks to both of you, you'd almost think we coordinated this. You fitted so well together there. There's a couple of questions have popped up in the Q&A that are related, but coming at the same thing from a slightly different angle. And the first one is around something that I am very familiar with, because I hear it quite a lot, is in terms of the incentivising investment in prevention. So the question relates to the challenge of generating enthusiasm, particularly in local government, because they perceive it as sometimes as that they're managing the financial investment and the risk, but not necessarily seeing the direct benefits. And there's another question there that's touching on the same thing from a different perspective, in that local government understanding the wider impact that investment is having might actually help to drive that forward. And Jim, you touched on it really, really clearly when you talked about the need to map the benefits on the other agencies and the fact that it's transdisciplinary. So I was just wondering, maybe Jim from a broader perspective and Mike from your experience in children's services, you know, how do we go about that? I mean, our work is trying to do it by shining a light on the how much is invested, but how do we get that broader view, that buy-in, where the benefit and the cost fall on different bodies?
I guess I'd say that certainly in Wales, I think the Future Generation of Wales Act outlines principles of how we should work together. And if you talk to people engaged in European analyses of public policy, one of the things they'll say about the UK is it permanently a closed system. What one central government department does impacts its delivery arms and actually doesn't impact across. So we're too siloed. So actually a lot of what local government in England does benefits the NHS. So there should be a requirement, I think, to risk share and benefit share in a way that I don't think we do in British across the UK, certainly not in England and certainly not in Wales. We don't yet do in our public policy and in our benefits mapping in the way that they do in some European areas or in the way that they do in some other nations like Australia. I think the other thing is that we have to get into the mindset of, if you're not going to pay for prevention, are you going to continue paying for failure? You know, the Mike's stuff is incredibly stark. Prevention is enlightened self-interest for most major public sector bodies. And we need to change that mindset. I think we also could do with some work by some actuaries. So, you know, I'd like to define people as actuaries as the people who are even sadder than I am. You know, they've given up statistics because they find it too racy. But some work by actuaries could really help us actually identify and map the benefits in terms of life expectancy to people. And I think we'd be surprised by the benefits for local authorities, not just the NHS, and for central government. We just need to join it up better.
Yeah, coming in on the back of that, Ellie, you would know. I mean, again, I was asked to fill in here on behalf of Martin Booth, the former Director of Finance, and I think what Martin was really struck by was that, and this is no criticism, you know, like for instance, you know, health improvement over a long period of time, where we talk about generational impacts, or I think somebody it was maybe Jim say, you know, you're not going to cash back on prevention. But what Martin was actually really encouraging about and really positive about was actually saying you're seeing medium term, you're seeing quick financial gains here, you're creating financial headroom really quickly. And that's one of the things about, you know, Jim's point about enlightened self-interest. I say, irrespective of where you sit on the political spectrum, this makes sense. And it makes sense in terms of both better outcomes and a greater adherence to the public finances. And again, it's very similar to, you know, Jim's point. We say, our former chief exec says, you know, in Glasgow, we've got to compete with Nottingham, Manchester and Amsterdam. We've got to economically, and I think people are now beginning to see a really strong connection between what you guys, you know, what Zach opened up with about saying we've got to bring these things together, and we either make it an entitled self-interest, but we've got to tell the story in a way, Ellie and Zach, that becomes, that we have to work through. How do we know penetrate? How's the story no winning closely enough? Because I think Paul and Joe and Jim are saying to you that the story's in the detail, and the stories in those 17 things that Jim talked about, and those are a mess. Those are people are in and out of those bits, and we need to be disciplined, and we need to get into being deliberate, and we need to slow down and go, what do we mean by this? Where's the failure, and where's the bits of improvement? And I think, you know, Paul's articulated, you know, some really great stuff in Scotland, and we're saying we've got to connect into those. But we've also got to connect into the devil and the analysis that Jim and Joe's brought today, and Zach, you know, that you've got to see what we talked about today is, you know, we could easily get into a room for 2 days and you come out the other side with a really strong, you know, implementation plan in each area about what it is that you need to do. And that, you know, it's a, you know, that's part of the thing, is that we created a bit of a bandwagon effect, and people started to, you know, we started to move money into prevention, and people started to see that you know, that this just wasn't talk, that we were actually saying we're serious about this, and we're serious about putting money into Saturday, Sunday, to working with families in a different way, to giving that money directly to families right into their bank accounts, because it was then about the sustainability makes such a difference.
Thanks for that, mate. And I think you're right, and I think it's you know, it's that when people start to see success, then it becomes more believable and tangible. There's another question in the Q&A, which is another common theme that I hear in prevention in relation to provision of evidence as to whether it works, and it relates to availability of data. So the question is basically, do you think that if public health and NHS data was available and became a feature of setting plans for delivery of services across local government and as part of their wider corporate strategy, do you think that would help in the shift towards prevention? Do you think it would help them to see the benefits and enable maybe a greater focus on embedding prevention into the planning?
Who wants to go first? Mike, do you want to ever go first, or?
I think the bit about, Ellie, just as you were chatting, I think the data, what matters to people varies. And this is one of the things that we are saying, is you need to tailor the story to what matters, what is going to draw people in. So that collective and distributive leadership becomes really important. About, for some people, some data really makes a difference for them. But for other people, it matters about, it's again that collective and distributive leadership. So I do think, you know, one of the things that we started to and again, Jim's point about the actuary is the bit about the data analytics has been really, really powerful on this. Because in the past, with loads of...
I think we maybe missed a wee bit of your answer there, Mike. I think the broadband's just cutting in and out a wee bit, but I think you got the gist of it.
I mean, I guess I would say that you need to work out what data matters and whether it's the experiences of real people or it's routine data and service data. So to give you an example, there's a project in Cardiff that's a voluntary group in the probation service, and people who have real serious health inequalities can go to that, as well as people who've been banned from the Cardiff Central Probation Office. There's no glass screens. In fact, I was there one day on a visit round and somebody came in who had been barred from the central office. I made them a cup of tea because the greeting is a sofa and someone making you a cup of tea. And we persuaded this person he had a leg issue, he needed to see a doctor about urgently. You're never going to capture that in quantitative data, but the qualitative data is important. And I would say we've got too many people who think quantitative data is the only thing that matters. I think having more data would be beneficial. But as someone who chairs two voluntary organisations, I would also say that the demand for data and evidence can be used as a weapon by the public sector not to fund the voluntary sector. And that's a game that we have to get over, and we mustn't allow it, because impact is what matters. So I think we need a more sophisticated approach to what data counts for impact of what you're trying to do. And sometimes actually the public sector, the data isn't there in the public sector.
Well, that's really helpful. And I think you're both right. It's about the dichotomy between having far too much data and using it as a reason not to do something because you can't see anything in it, and having the right data to achieve the aims and purpose that you're setting out to do. I'm aware that we're running out of time, but there is a question in the Q&A I don't want to ignore, but that I can't answer. So there's been a question about whether there's a role for CIPFA to add behavioural economics into our PQ or as a separate course. Inspired, I'm sure, by I'm not the person to answer that question because I'm not involved. I'm a policy person in CIPFA. I'm not involved in the design of the PQ, but I will certainly take it back to my colleagues in CIPFA Develops because I think that's a really interesting idea.
Yeah. All right. Well, big thank you to Mike and Jim for your insights. We'll be sure to find a way to share all of the slides with participants today. I think there's a lot of information in those slides that would be really valuable for all of us, regardless where we're working. So that's great. We'll take another short break we're down to 8 minutes now, and the third session on investing in prevention with Vicky Davis, whose timing is impeccable, will start at 3:10. So we've got a few minutes again to fill up your mug, stretch your legs, and we'll see you back here in a few minutes. So thanks again, Mike and Jim. All right, I think that's the sign from Monica, our events coordinator, that the clock has struck 3:10 and session 3 will start now. I'll just call my colleague Ellie back to the floor. So I'll be passing off my moderator hat to Ellie for this session, and I'll be following Vicky's presentation with a little bit of an overview of what it is CIPFA is trying to achieve with its work. So I'll pass things over to you, Ellie.
So apologies, you're about to experience a significant decrease in the quality of chairing. As Zach said, he's going to actually switch to presenter mode for this session, and he's joined by Vicky Davis from the NEO, who's going to discuss the report that they have done recently on homelessness. So session 3, the focus is on investing in prevention. I think we've kind of touched on why this is important in some of the ways that it causes problems in the previous session. I'll just remind you of the Q&A box. So if you do have any questions, then please drop them in there. Otherwise, you'll be left with whatever I come up with at the end. So with that, I will hand over to Vicky Davis, who's Director of Local Government and Value for Money at the NEO. Thanks for joining us today, Vicky.
Thank you for having me, Ellie. Can I just check if you can hear me okay?
Loud and clear.
Lovely. Okay, and hopefully, next question, can you see some slides on your screen?
Can indeed.
Ah, winning all round on a Thursday afternoon. So yes, thank you. So I'm the Director for Local Government Value for Money at the NEO, and I'm here to talk a little bit about a report that we published, gosh, it feels like a long time ago, July 2024, into homelessness. So just to kind of explain where this report came from. Oh, hang on. Sorry, I have minimized something and lost my slides, which was handy. Let me just stop sharing and restart again. Sorry about that, Ellie. Right, here we go. There's a secret here. Don't press any buttons. No, they have gone. Sorry, I think you can all see them. I cannot. Here we go. Here we go. Right, got them. Sorry about that. So yeah, just to explain why this report and why now. So we had previously reported on homelessness in 2017. We'd also reported on rough sleeping as part of our COVID response pieces, which I'll come on to a bit more in terms of the distinction. But it's not the first time we've reported on homelessness. The reason we did the report when we did in 2024, of course, that's when it publishes. We started work on this and thinking about it way back in 2023. And the reason in terms of timing why we felt it was important to come back to this was partly follow up on what we had said in 2017, particular recommendations. There was some really quite critical points made in that report about government oversight of this challenge, a push for a strategy and the like. And again, we'll touch on that a bit later. But this was also becoming very clear that the cost of homelessness, as well as the human cost, also the financial pressure of tackling homelessness for local authorities was becoming this really emerging and significant issue for them. It was really starting to catch up with people talking about social care, financial pressures, and also the cost of special educational needs and meeting their duties there. So it felt like this was the right time to come back to this. The other reason is that the Homelessness Reduction Act had come into force in 2018, so after our first report on homelessness, and so it felt a good time to follow up and see what was happening. Okay. So to come back to this idea of what we mean when we say homelessness, what it isn't, it's not rough sleeping. So here what we're applying is the statutory definition, statutory duties that local authorities have around homeless and homelessness, which is to certainly post the Homelessness Reduction Act in 2017, there were 3 aspects to this duty that local authorities have to consider. So they are set out here. I believe you get the slides after this, so do not worry about all of the detail and whether you can read this in time. I'll walk you through. But I suppose if you think about, what everyone is talking about today around prevention, this is the left and middle boxes on the screen. So there's a duty for prevention here for all eligible applicants, irrespective of local connection, priority need, or intentional homelessness. And so this came in terms of the Homelessness Reduction Act brought this in. And essentially what the prevention duty means for local authorities, and there's some descriptions at the bottom of that box, it's really about stopping someone's circumstances changing. So if it looks like there is a risk of them becoming homeless, there looks like they may lose rental accommodation, for example, that the local authority takes steps to help someone alleviate that pressure. If that hasn't worked and you're into the middle box, that's relief duty. At this point, I think you could still say this is a form of prevention. And what might happen here are things like looking for alternative accommodation. So, okay, the housing that someone was in, that that's not working for some reason, that they've moved out of prevention into relief. Well, what is available? Is there other housing that can be secured for them, for example, in the private rented sector or social housing? So it's about looking for alternatives. Again, you're still preventing homelessness. And if that hasn't worked, you're into the box on the right-hand side, which is the main duty, which is where someone finds themselves homeless. And that's where really the main duty is about providing temporary accommodation. So to take the left and middle boxes, so prevent and relief duties, this is what this has looked like in terms of numbers of households in prevention and relief, requiring prevention and relief duty, since these were introduced as part of the Act. So since they came into force from 2018 and through up until the point when we reported, which is the latest data we had was 23-24. On some of these slides, you'll see some more updated figures that have come out after our report. So they will be there for you. And so what you can see is a trend upwards. I will say that the most recent quarter's data has dropped off, but also there are some fluctuations. You get seasonal fluctuations through this picture, but an overall upwards trend. And I've also included in here some statistics that we can get from the official data on homelessness, which I think are quite interesting. So see, over a fifth of these people at 23-24, a fifth of these households had people in full or part-time work. Almost a quarter, they were in this position because they were coming to the end of a private rented sector tenancy, and I'll touch a little bit more about that. But what's happened in the private rented sector market has been really important and impactful on homelessness numbers going up. And I think the other thing to say also, as we often say in any sort of service that's delivered, it can be quite complicated, and there will be people in this position who have got additional needs as well. And actually more than half of the households that are shown on the right hand side of this in 23-24 had those additional needs. So to come on to the other side of this, so when the prevention and relief duty hasn't worked and people find themselves requiring that main duty and they find themselves in temporary accommodation, this is what the picture has looked like for temporary accommodation. And we've taken this back to 2002-03, which is when the comparable data really starts from. So at the point we reported again, 23-24, we had the highest number of households since comparable records began in temporary accommodation. The red line being total households, the blue line being households with children in, and you can see obviously a very similar pattern. I'll talk about the little fall in the middle in a moment, but there was a lot of factors at play here. Some economic, so rent increasing faster than people's income, so a real affordability problem, and of course affordable housing supply falling behind targets being another big factor. There's also government policy at play here. So what happens around benefits, the benefits regime, another very important factor in whether people can afford, for example, any accommodation in the private rented sector, and also government policy around housing supply and how successful delivery of housing targets have been met. And actually, again, we report that they haven't been met. So previous housing targets have not been met before. So just the bit in the middle where you get the downwards trend. So what was happening there was a very public commitment to halve the number of households in temporary accommodation. And so there was very much a very public statement. Everything was being galvanized around that. There was things happening around housing benefit as well as recognizing an important factor in this. So I think, again, it's interesting to point out that while we're at the highest levels ever now, and we haven't ever gotten there, we have been quite high in these numbers before, and we're able to get these down. Just a quick one. We love a map at the NAO if we can get a map in a report. This is just to give you a sense of how the numbers in temporary accommodation break down across England. Dark blue being more households as a proportion of overall households in temporary accommodation. And yes, you can see there's quite a lot of variation. You can see a concentration in urban areas, which is, might be expected. But you can also see some patterns in rural areas as well. So I think the Southwest is quite notable in terms of, actually having reasonably high numbers in temporary accommodation. What this could sometimes mean, particularly in areas where there's a lot of people requiring temporary accommodation, is that people might be placed out of area. And I think that one of the points we've made is around the data as to how many people have been placed out of area being better. Actually, it was a 42% increase between 18-19 and 23-24 in terms of numbers of people placed out of area, which obviously has a big impact as well. And conscious of time, so I won't dwell too much on this because I want to get onto the prevention numbers and spending. You can see this, a form of TA commonly used now as local authorities turn to what they can use in an emergency is bed and breakfast use. And again, a very similar pattern to what we've seen in overall temporary accommodation numbers. Draw your attention to the dark blue line at the bottom, which is actually households with children that are in this kind of accommodation for more than the maximum 6 weeks that the guidance says they should be in. And obviously a lot of quality concerns here as well. So actually just thinking on this theme today, if you're a household with families in this kind of accommodation, you may then start to require extra needs and services that you wouldn't otherwise have required. So again, another point around prevention. It's not just about homelessness, it's an intersection with lots of other public services. Okay, on to the spending side of things. So if we take the last column on the right, so this was the latest available financial data that we had at the time. What you're seeing is the dark blue is what was the proportion of spend on temporary accommodation, the middle chunk being what's going on prevention, if you like, and the red being everything else in terms of housing services. I should say, it doesn't include housing revenue accounts, so it doesn't include an authority's own investment in its social housing. In terms of numbers, TA, temporary accommodation, making a much bigger amount, making up a much bigger amount of that. But I think the interesting thing is actually the red. So it's the decline in that red bar, which is things like housing strategy, housing stock, housing benefit, housing welfare, and the spend going out on that as a proportion, while not labelled prevention, I think you could say is a form of prevention. Okay. On to funding, and Ellie, you might just need to wave at me if I'm really going over, but 5 minutes, I promise. So for the funding landscape for homelessness and of course many other public services that local authorities are delivering is really quite difficult. It's fragmented, it can be uncertain. And our report, we set out, there's probably more, we set out 13 funds or programmes of access that linked in with homelessness. Some of these are from different government departments, makes planning really, really hard. Some were allocated, some were to bid into. I think it's, the conversation about the short-term nature of the funding and the one-year funding cycles for local authorities is kind of well trodden. But of course, that does make it very difficult to plan strategically. And how this plays out for a local authority is, for example, in their housing team, can they take on permanent staff or have they just got temporary staff because they don't know if they can afford a contract beyond the next year? And that does limit a lot of the investment that a local authority can do in this space. And obviously we've heard, a commitment to multi-year settlements to come. And then the other interesting thing is something called a homelessness prevention grant, which I think is well intended. It was not ring fenced, so local authorities had local discretion to use it as they needed. It is something of a misnomer because more and more of it has been used on temporary accommodation costs. As those costs have risen and more people are coming through the system, more of that grant isn't going on prevention. And the chart on the right is actually some stats and analysis that is publicly available by MHCLG, which kind of shows, and going back to the chart that I showed you earlier, the map, it's not surprising that particularly in London and the South East, the amount of that grant that's going to temporary accommodation is up above 50% in London, and just under in the southeast. So that's a standout, really. I will perhaps come on and talk about benefits later in the Q&A. I won't go into a lot of the detail, but essentially the local housing allowance rates, which drive the amount of money local authority can reclaim from DWP to pay for temporary accommodation costs, has been frozen. It's been frozen for a good number of years. So actually the gap in terms of how much temporary accommodation costs an authority and how much they can recover has grown and grown, which again just puts more pressure on things such as the homelessness prevention grant. So to come in 25-26, there is more money going into that grant, and also there's a form of ring fence going to be applied. So there's a sort of threshold beyond which an authority shouldn't go in terms of how much of that is spent on temporary accommodation. I won't dwell too much on the report conclusion. We say quite a lot about how the situation has worsened, and there's record levels in homelessness. The funding fragmentation point I've already mentioned. We talk about the fact that this is a cross-government issue, and that these things need to come together along with a strategy for people to get behind to resolve the situation. And you'll see on the right, we made particular recommendations to both MHCLG as the department with policy responsibility, but also to the Treasury to think about what are the system ways they can incentivise that greater focus on homelessness prevention. Finally, there has been a Public Accounts Committee session on this topic. There is a link on this slide that you can go into if you would like to know more. I've included it just again so you can see how the Parliamentary Committee has recommended what they've recommended alongside the NAO recommendations. Again, a focus on incentivisation, how the department might work with local authorities on the ground to sort of improve prevention activities, also sharing what's working between authorities as well, and reducing bed and breakfast use. I'm sure we'll get on to some of these other aspects. I will just say that there is now a strategy to come on homelessness, excuse me, and a cross-government task force as well has been set up, as well as some increased funding going into the system. I will leave it there, Ellie. Thank you.
Thank you very much. And you didn't go over time at all.
Fabulous.
So we've got one question that's popped up in the Q&A. Might need to ask the person that's asked the question to give us a bit more detail. But the question as it's written is, how is prevention and relief defined? We're coming back to that definition issue again.
Yeah, okay, thank you. And thank you, Jeff, for that one. So I think the definition as we have it and as set out in the Act is, I suppose, the distinction between the two. The prevention is there because someone's at risk of something happening. Relief is there because that thing has happened. And so while we call one prevention and one relief, for me, both of those things are a form of preventing someone from requiring temporary accommodation. So I think, yeah, so if we think about the first one, say, you know, you're going to be asked to move out of a property that you're renting and you cannot find anything that you can afford. At that point, that's when a prevention duty comes in, because that's about, can we stop that circumstance changing? Can we talk to the landlord? Is there anything that we can do? So it's these sorts of things, or someone's living with a family member and that for whatever reason that circumstance is not going to be tenable. You know, a local authority may decide at that point, well, what can we do here? Can we try and improve that situation so that doesn't happen? If at that point that none of those things have been successful, that's when you're in relief duty, because for whatever reason the accommodation you were occupying is not viable for you anymore, and then you need something else. And the relief bit is, what is the something else that's available to you? I hope that helps, Jeff.
So I might be being overly simplistic, but if we wanted to sort of apply a more public health definition to that, you're almost talking about prevention as being the primary stage of prevention, and that you're trying to prevent the problem from occurring. whereas
Yeah.
it's more like the secondary element of prevention, where the condition is already present, just trying to prevent it from getting any worse. Yeah?
Yeah, it's as good an analogy as ever, Ellie. Yeah.
I was really interested, obviously, in the common theme that we keep hearing across the board about lots and lots of pots of funding that aren't available for very long. But 13 surprised even me for one area of homelessness. And the point you make about the elements of the prevention grant actually being spent on, you know, the slightly more acute area of accommodation. And it's the eternal question of, without ring fencing, which we know is not the most popular thing, how do you make that shift back to that prevention grant being spent on intention? Is it just about more money for acute services, or is it about pushing the activity further upstream?
Yeah, I mean, it's a really interesting one. There's been a lot of, you know, there is some talk about, you know, double funding. Do we need to double fund? Because essentially you've got this acute need at the end in terms of people coming through that require temporary accommodation, and that can be really expensive. But all the time you're doing that, you're not able to bring the investment upstream to stop that happening. And also some of the things that you might do in a prevention space, if we think about housing stock and the like, you know, they have a long tail. It takes quite a long time for those things from the initial thought and investment to actually them being up and ready and serviceable. And so there are people that talk about double funding. Now, we don't talk about that. That feels very much like that's in a policy space that we won't go into. What I would say is I don't want anyone to get the impression that there is not a lot of good work going on around prevention. There really is. I think a lot of some of what we were saying in the report, and certainly things that the Committee of Public Accounts were picking up, was how can that be better shared so that, you know, what is working in an area is made known to, you know, perhaps other local authorities to try again. So perhaps that reduces the cost to them of trying something and it not working. But there is also the point of, how do you manage down that demand for temporary accommodation? And is there anything you can do at that tail end that kind of reduces the costs? The other aspect in this, Ellie, which I say I wouldn't get into because it's horribly complicated, but you know, there is quite a live debate about local housing allowance rates, which are used to set the level of temporary, well, they used to do two things. They used to set the amount of housing benefits someone could get, but they're also used to set the amount of temporary accommodation subsidy that a local authority is entitled to. If that gap just gets bigger and bigger, as it has been growing, then you can see why local authorities have less and less to invest in prevention. So again, there have been questions asked. There have been questions asked at the Housing, Communities and Local Government Select Committee about, you know, is there an impact assessment done of what not increasing the local housing allowance rates means for this position as well. So I don't think it's never as simple as just more funding. It's what type of funding, how delivered, to do what. And I think I think ring fencing can be really challenging. And I think having a pot that wasn't ring fenced, that is now partially ring fenced, I can see that could be quite difficult for local authorities as well. But I can see the intention behind that for the government as well. So I think it's a really complex picture. I think just to your point on the 13 funds and programmes, and actually we heard a lot of people say it isn't about more funding, it's about more rational funding. Because, you know, and to our mind, you can get better value for money when you know what's coming, you know what you've got to plan for or plan with on that basis. You know, you're going to tend to get better value for money from that. And as well, if you can plan and deliver that investment over a longer time frame. So I think all the things about, you know, pooling resources, simplifying the number of funding streams, giving that sort of more than 1 year certainty, you know, all of that helps as well. And that doesn't necessarily mean more money.
Thanks, Vicky, that's really great. And I can see Zach looking nervous because I've detracted from the agenda and gone into Q&A because I got too excited by your slides. I am going to hand over to Zach to talk about the work that we're doing with the Health Foundation on looking at levels of preventative investment in local government. I just suspected that some of your answers might be helpful in setting that up. Thank you very much.
Yes, for sure. Thanks, Ellie, and thanks, Vicky, for your presentation as well. Just want to double check that you can see my slides clearly here.
You can see them full screen and you're coming through loud and clear.
Perfect. All right. So I wanted to take a few minutes to connect some of the presentations that we heard today with the work that we are doing at CITFA with the Health Foundation on exploring levels of preventative investment in local government. So as Paul and some of the others mentioned, the focus of statutory funding really over the past 15 years has shifted toward acute services, often at the expense of prevention. And Paul highlighted the example of children's services. Vicky has just highlighted this example around housing. And this is this has major implications for the health of our communities, but also the sustainability of public services. And there's one statistic that we keep going back to at CITFA and on this project team that's outlined here on the slide. In England, by 2040, there will be a 30%, sorry, let's try that again. In England, by 2040, it's expected that there will be a 37% increase in people living with major illnesses, but at the same time, only a 4% increase in the working age population. And this statistic holds true in the devolved nations as well. And I think to us, it's almost an alarm that's been rung in that this isn't just an issue for the NHS or for social care services. It's an issue that's shared across all public services. And if we really do hope to ensure the sustainability of the services that we all take advantage of, then it's something that needs to be addressed. So the message here is that reactive spending threatens the sustainability of public services. Now, enough with the doom and gloom. I think we have a great idea of where we all are. And it's important to think about solutions as well. So I mentioned at the beginning of the webinar some of the ideas that have been brought forward. So we have the Hewitt Review, the paper by Demos that Joe mentioned around PDEL, a new category of expenditure limits. The IPPR released a report on health as our greatest asset, looking at new funding strategies there. And then CITFA's own proposal in our report on integrating care. So it's starting to feel that although we may be looking in different areas, the policy community is more or less on the same page when it comes to prevention. It's now something that is essential to move forward on. But there is one unanswered question from our perspective, and that is how much is being invested now. So back in 2019, CITFA did some work with Public Health England, looking at evaluating preventative investments. And although for that work, we were looking specifically at the UK health accounts, I think the findings ring true for this work as well. The report concluded that the key to putting a greater emphasis on prevention is understanding the current position and the future implication of not making such investments. And so what we're trying to do through this work is address that first point. Can we understand the current position? And so a little over a year ago, a project on exploring levels of preventative investment in local government in England was born with the support from the Health Foundation. And we set out to answer this question. To what extent can we quantify local authorities' levels of preventative investment related to the building blocks of health? So if we break that question down a little bit and think about why the building blocks of health, why local government, if we go back to Joe's slide and we try to imagine all of those building blocks put together, things like housing, good work, skills, education, and so on, a lot of those building blocks correlate to services that are provided by local authorities. And so that's why we've decided to narrow the focus in on this area in particular. So we broke the project down into 3 steps, and we are planning on producing a final report that will be published at the end of October this year, so October 2025. But I'll just run through those 3 steps quickly and share some of the initial findings and observations that we have. So the first step was to establish a scope and definition of prevention. And as Jim mentioned, it's important to be precise, but that can be really difficult, especially when it comes to prevention, in that everyone seems to have a different idea of what that means. So a lot of people will turn to the NHS. Some are turning to fire and policing services. So that was the first challenge, and I'll get into that in more detail on the next slide. The next step was then to co-produce plans with partner councils. So we issued an invitation to participate to councils across England and asked them to come up with a proposal for what they may like to explore. So for us, this project is really about proof of concept. If we can build a framework that works well to measure levels of preventative investment in one specific area of a council, in theory, we should be able to level that up and look at spending across an entire council, or perhaps in the long run, have a better view of preventative spending across the entire country. The next step was then to map preventative activities and identify levels of spend, and that's where we are now. And I'll touch on some of the challenges that we've encountered in doing that. So just to go back to defining prevention, and again, we'll share these slides with you, and all of the images are linked to articles and resources that will hopefully be useful to you. But we ultimately landed on 4 stages of prevention, which are listed out on the slide here. Many of you will be familiar with 3 of them: primary, secondary, and tertiary prevention. We decided to go a step further upstream, so before primary prevention, and included primordial prevention. Now, we're still working on the wording of this. I think there's a balance to be met there around precision and usability, but that's a conversation for another day. But primordial prevention is sort of that highest level upstream. So we're thinking about the social and economic and environmental factors that shape health, and in fact, prevent risk factors from emerging in the first place. So if we kind of break it down and think about to what extent has a problem manifested, what's the target population, what's the primary purpose of a primordial preventative activity, we can say that the extent to which the problem has manifested, well, it really hasn't, but there's potential for risk factors to emerge if we don't address those underlying factors. If we think about the target population, primordial interventions are often targeted at the population as a whole. They tend to be universal in nature. And the primary purpose, again, to limit those risk factors from emerging in the first place. So that was a slight addition that we made, and we're still working on in terms of the details and how we operationalize that with local government. So any comments or questions you have around that would be greatly appreciated as well. The other thing that we did was remove health-specific language from these definitions. So often, if you think about primary, secondary, and tertiary prevention, they're rooted in public health or medical literature. And we wanted to ensure that our definitions would be applicable to wider public services. And so in attempting to do that, we've removed health-specific language. So the same definition could, in theory, be used to look at interventions by the NHS or more traditional public health interventions, but of course are also applicable to things like homelessness, housing, employment, and so on. So jump forward now to identifying our partner councils. As I mentioned, we made a call to invite local authorities to submit a proposal and get involved in the work. We've identified 4 councils that we'll be working with so far, each of which has identified an area of focus, an element of the council that they've been putting particular energy in or have been experiencing challenges. So a lot of the challenges that Jim mentioned have cropped up, And in addition to these partners, we've been having conversations and sharing resources with councils across the UK, so not only within England, obviously recognizing the limitations there. And unsurprisingly, many of the challenges that Jim outlined have come up, one of which is sort of working through siloed working and trying to shift culture within local authorities. And we found this next bit in the third step of our work to be particularly helpful in doing that. So the next step after we had established plans with each of the councils was to map out all of the services that relate back to the areas of interest that the council identified, and then to collect financial information, which is what we're grappling with right now. But I think in particular, when it comes to service mapping, it's not something that can be done solely by finance teams or public health teams, and it really requires the involvement of the entire council. So to give an example from the London Borough of Merton, they're looking at a council priority, which is to build a borough of sport. And so at the surface, it may seem kind of simple. You can think of the departments across the council, well, parks and leisure, recreation services. There's probably going to be a lot that falls under that category. But when they brought members of the council together, from service delivery teams to the public health teams to the finance teams, they found that in fact that priority is supported by almost every department across the council. And it wasn't until they were able to work together like that and create a map in one place that they could really see the full scope of their work. So I think this goes back to what we were saying about a lot of preventative activities being absorbed or embedded in everyday practice, kind of business as usual. But by highlighting that they're preventative, we can really put a focus on the importance of supporting and sustaining those initiatives. So just a few points here, some key data points that we're asking local authorities to gather as they do this. The first is the stage of prevention. And as part of that, we're asking them to include a rationale. So they need to identify the target population and the primary purpose of all of those services that are playing into the wider council priority. We're also asking them to look at the service providers. So as we know over the past years, the third sector in particular has stepped up and is now providing a lot of services that local authorities used to provide in the past. And so we're asking councils to identify whether it's them providing the service themselves, if it's another public sector organization, a third sector organization, or in some cases, a private organization. And there's definitely a lot of conversation going on in that area too about how to involve all of these different parties. Then, of course, we are CITFA, and so we need to look at expenditure and financial information, which is proving to be quite difficult because of the scope of a lot of this work. I can see Ellie laughing there. We have a meeting tomorrow with Merton to try and iron out some of the details, but we're interested in both capital and revenue expenditure. We wanted to set the bar quite high with this project. So a lot of questions obviously emerging around capital expenditure and how you account for that. But that's something that we're working on and can hopefully share results as we go. And then finally, looking at the funding source. So common issue that comes up in conversations with councils is around the sustainability of funding. So we're really interested in seeing if these activities are funded predominantly by council's core budget, or are they kind of one-off, time-limited grants or other sources of funding. So more data to be collected there. But that's a really quick overview of kind of what it is we're trying to do and where we are with the project. So just in terms of next steps, we will continue over the next few months to work with councils to map services and measure investment. And in the end, we hope to develop a framework for quantifying preventative investment. And so again, it's about proof of concept. If we can do it well in one area, if we can build that broad framework, then I think this work would not only be applicable for the 4 councils that we've identified in England, but for councils and governments across all 4 nations. And again, just a reminder, the final report is due to be published at the end of October 2025. So do keep an eye out for that. And I think we'll be sharing some links to CITFA's webpage and the newsletter where you can catch updates on this work as it progresses. So we have a few minutes left if there are any questions, but I'll pass it back to Ellie to continue the conversation.
Thanks very much for that, Zach. A whistle-stop tour of our own project, which has stunned the Q&A box into complete and utter silence. So just a reminder, if you do have any questions, then please do drop them into the Q&A. Vicky, can I pull you back in just for a little bit of a panel discussion, just while we let people's brains turn over and come up with some questions? I thought you left.
No.
So, I mean, I think Zach's presentation made it really clear a lot of the issues that we see around prevention is related, and a lot of the confusion we see around prevention is that quite often people don't really know what we're talking about when they're talking about prevention. So we've spent a lot of time on the definitions. When we start to look at the financial data, you have to then make sure those definitions work for the finance people as well, which is why I was laughing during Zach's presentation, because that's proving a huge challenge. And I'm starting to understand why nobody's done this before. But just out of interest in your experience at the NEO in value for money work, obviously you're working with sort of government financial information, and how easy is it to access that? And part two to my question, is it granular enough to be able to pull out preventative spend? I mean, obviously in the homelessness report, you've managed to a certain extent, but in other areas, I mean, it's part of the reason we're doing this is because we can't find publicly available data. So experience be across the government departments in the work that you've done, and do you have any suggestions to improve it?
Yeah, and as Zach was speaking, Ellie, I was thinking, oh, we should have a separate conversation, because at the moment we're publishing a report on local government financial sustainability at the end of February, and we talk about prevention quite a lot in there. And without issuing any spoilers, I think sometimes we have to take a bit of a proxy as what you might consider preventative activity. And even there is something about terminology, isn't there? It's like, what are you saying is an early versus late? You know, that you can get into what's early and what's late intervention as well. So it's definitely something there about terminology that we sort of feel the pain with as well. Obviously, we have access to the data that's there. When it comes to local authorities, as you will know, a lot of the starting point for us when we look at this data is, I suppose, is there a nice statistical release, as we have in the case of homelessness, although I think that is as much about numbers of people and households as it is about spend. The spend data still comes through returns from local authorities into MHCLG, and so we are quite driven by what the categories are in those forms that local authorities are, filling in their numbers against. With, again, with options to dive into local authority accounts themselves in terms of published accounts, if we want a level of detail. But obviously the number of authorities means we seldom do that. So our starting point is always the MHCLG data set. And I think there's a separate conversation to have on that, as how we've used it in our particular piece. But I certainly recognise the challenge there, and I think, as ever, there's something around proportionality, isn't there, of what the ask is of local authorities, and I think the aim there is to hit on a sweet spot where the local authority is already collecting that data because it's of value and interest to the council itself. And then it's also something that is of interest to other people, such as CIPFA, the NEO, government departments and the like. I think it can be quite service dependent as well. So as you will know from health, and there'll be a lot of other data sets around that, and there will be on things like children's care and adult care, where perhaps you can kind of get to, but it does sometimes feel like you're sort of taking a sort of definition as a proxy for prevention. It's not labelled as prevention in a nice neat package. I certainly recognise that challenge.
Yeah, it's one of the reasons, I mean, one of the reasons that we've undertaken this is because, you know, we know, some of you in the call might be aware that CIPFA are responsible for CERCOP, the categories on which the infamous local government RO returns are based, and we can't see enough prevention investment in it. So this work has an external question to try and help local authorities learn some more about what they're spending to make decisions, but it's also an internal question for us at CIPFA about, well, are these categories, as the problem of the categories, do we need to do something about that? My colleagues really get worried when I say that internally. So we've come up to 4 minutes to 4. So Zach did quite a good job of summarising the rest of the presentations in his presentation, actually. But I would very much like to thank all of our speakers for joining us today. I think, in my opinion, you've all been fantastic, and I think you've done a fantastic job of linking between each other's presentations as well. Just in terms of closing remarks for me, my observations from the day, you told me what I already know. This prevention business is extremely complex. I think going from the building blocks through the barriers, through how we shift investment towards prevention, there are clearly some common themes, not just at national level across involved administrations England, but also at local level. And I think that was brilliantly illustrated by the second session with Jim giving his perspective from Public Health Wales, and then Mike showing us exactly how that applies at local level from the work they've been doing in Glasgow. I think my favourite thought for today was 17 reasons why prevention fails. And that's because I'm an old scientist, and as a scientist, I know that the only way to succeed is to learn from your failures. So I am absolutely motivated by that. But also the points about the need to go way beyond the ROI and start to map out those benefits and get them seen across organisations so that we can start to see the interdependence of our public services on each other, not just in terms of the health benefits and the financial benefits, but the impact on demand for services across the board. And I think I would give the final thought of the day to Jim McManus saying we can't afford not to prevent. There's many reasons and barriers and challenges of why we maybe don't do it as much as we should, but we're already starting to see the build-up of acute pressures across all of our public services. So if we don't do it now, then when do we do it? So just to close down the day, somebody has put in the Q&A box that they are using a very similar approach to look at preventative investment in Rhondda and Taff Council, and we would very much like to hear from you because we are looking for case studies of anybody that's sticking a toe into these waters or thinking about approaching a preventative project or looking at evaluation or looking at how much they're investing. We would love to hear from you. Our project has focused on councils in England, but we are really keen to showcase what's happening across the UK and beyond. So I think Zach has a slide with how you can get in touch with us and how you can find out more. So if you want to learn a bit more about our prevention project and related work, then you can use the QR code there to go to our CIPFA webpage. We also have a CIPFA-wide LinkedIn newsletter to which Zach and I are both regular contributors, and the word prevention usually features in pretty much everything we write, but Zach will be doing regular updates on how this is going. So thanks again to all our fantastic presenters. Thanks to Zach for doing the project in the first place and for arranging this webinar and a fantastic schedule. And thanks to all our attendees for spending a few hours with us this afternoon. We hope it's been helpful and interesting.